All right, next up we have an update on maternal mortality and social determinants of health from Dr. Erin Duncan. Dr. Erin Duncan is a partner at Atlanta Gynecology and Obstetrics in Decatur, Georgia, where she's been serving since 2017. With a diverse background spanning medicine, public health, and social advocacy, Dr. Duncan is a respected figure in the field of women's health. Her academic journey includes a dual MD-PhD degree from Emory University, where she also completed a residency in gynecology and obstetrics. And during her time at Emory, Dr. Duncan delved into research exploring the impact of maternal hypertension on perinatal outcomes, shedding light on critical aspects of women's health. Her expertise and dedication have been recognized through numerous awards, including Excellence in Resident Research and Outstanding Resident Awards from Emory University. Dr. Duncan continues to share her knowledge through presentations and conferences and academic forums, aiming to advance the field of women's health. So we'd like to welcome Dr. Duncan up.
So I wore my big girl shoes, but we're going to let this go down just a little bit more. All right. And the clicker is here. And this is forward. Okay. So we're going to go back a little bit in time, and I'm going to share a small part of my story. I think Dr. Warren did a really good job telling us about kind of the forest and going to the trees, and I want to try to go from the trees into the leaves, and some of these themes will come up again. Some of our slides are eerily similar, so we can talk about that. But for me personally, in between undergrad, which happened to be at Vanderbilt, so again, full circle, I did a gap year in Nicaragua prior to starting medical school. And one of the things that we did was we ran a child sponsorship program in one of the city dumps, so like literally a landfill. And we had them specifically for children that were deemed to be medically malnourished, so they had a BMI less than 18, many of them less than 15. And those children would be able to get nutrient-enriched oatmeal, milk, and vitamins every month. What we realized pretty soon was that kids like Alba, who's down there, this happened to be the sickest member of a very large family, and so it was very difficult for their parents not to give some of that food on to the rest of their children. And so we started doing maternal health and just kind of public health conversations with the moms in the community, realizing that if we can arm the family with knowledge, then they can take care of the rest of the family while we focus on the sickest members. And that's really where I found that I was interested in women's health, maternal health, and also in public health. So going into the objectives of our talk today, we're going to be going into the mission and the history of the Georgia MMRC, recognizing the significance of preventability in maternal deaths. The leaves that I really want to focus on today is the implementation of key informant interviews, and we'll go into that in depth. We're also going to discuss the causes of pregnancy-related deaths in Georgia, review social determinants of health and how they impact those deaths, and then give some recommendations and hopefully give y'all a charge to move forward afterwards. So when you look over on the left side, this is going to be kind of the broad aspects and the mission of the all maternal mortality review committees. When we speak specifically to Georgia's, it's led by the Georgia Department of Public Health. It was established in 2012, so just to go back to the logarithmic scale that Dr. Warren gave, death certificates were used starting in 2010, and within 2 years we were examining those deaths. We have completed our case review up until 2021. We have key informant interviews. We started that in 2020, looking back at deaths for 2017, so that will be my main milestone for my slides. And at this point in time, 64% of our cases have a key informant interview, meaning that we have a dedicated social worker that is reaching out to the families of people that have had losses to see if there's any additional light that they can shed, any additional questions that they may have, and also to have both their feedback for things that we can do better and then ways that we can help them. Our committee itself is quite diverse. We have over 30 committee members, and 40% of them are non-clinical. And part of the reason of that is because we're trying to include members that are representing communities that are disproportionately affected by pregnancy-related deaths. This is called the Maria form. This is one of the main forms that we use when we're making our discussion and our designations of different pregnancies. And I want to focus on two areas. So one is the pregnancy-related list. Can you read that? Is that too small, the font? Yeah, okay, all right, so I wrote it down. So for a pregnancy to be deemed to be pregnancy-related, okay. Oh, thank you. Hey, all right. It is a death during or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by the pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. Okay, so that is an important note. Okay, and that is something that for the most part, since the beginning of the review committee, we have been able to come to that conclusion, although sometimes we can say that we're unable to determine. This box over here, prior to 2020, was a little bit more difficult, where we're saying, did obesity contribute to the death? Did discrimination contribute to the death, which is very, very difficult to ascertain from medical records? Did mental health conditions contribute to the death? And did substance use disorder contribute to the death? So there was, prior to our key informant interviews, these two middle questions. We were sometimes using conjecture, frequently saying probably or unknown. And that's just, when we know that these are important aspects of life to be looking into, it's very frustrating for us to not have the information to be able to make those decisions. So then we went in and started having the key informant interviews. They were able to perform filling gaps in the information in the records. So they frequently can say, well, you know, she briefly moved out of the state of Georgia and got care here for this amount of time. And we were able to then move into that state and ask for those records. Or she was in jail for a certain amount of time, and we were able to get that information. So we can have more complete records. They also are very instrumental in enhancing our recommendations as a group, because they can give us details on contributing factors and the chain of events leading to the death. And really, they're giving us the lived experience. So not just looking at a medical record, not just looking at vital signs, but really giving us a really beautiful portrait of who that person was. It's also important for the communities and for the informants themselves. They have all gone through a trauma. They've lost a loved one. And what these interviews do is they show that there is at least somebody in the state of Georgia that cares that this happened to them and that we are trying to change that. And so some of the actual quotes from the key informants include, I want to tell you how much I appreciate being able to have this conversation. On behalf of my whole family, it's important to us to know that Georgia really does care. So I think it's really a cathartic and therapeutic moment for multiple people involved. When we're going into the cases of pregnancy-related deaths in Georgia, again, I'm going to look into the lens of prior to the key informant interviews and post-key informant interviews. This is almost the exact same slide. It's just that the date is a little different than what Dr. Warren showed us earlier. All cardiovascular conditions are, prior to 2017, all cardiovascular conditions was the predominant cause of death. We had hypertensive disorders of pregnancy over in spot number 3, and then infection at the end. And then post the key informant interviews, so again, this is also in the light of COVID, but we still see cardiovascular conditions, infection, that was mainly COVID-related deaths, hemorrhage, but then we see this new actor of mental health conditions. And Dr. Warren has already spoke to the fact that there are some racial disparities between those. That's not the point of this conversation, but it is very much the point of this conference today, so there will be a lot of discussion about that. When we are reviewing the social determinants of health and how they impact pregnancy-related deaths, and then looking into recommendations to prevent pregnancy-related deaths, I'm going to have some kind of de-identified combined case studies to look at that hopefully will be able to show just a little bit more of a personal aspect of this. Have you seen this slide yet? Yeah. So part of the reason that I liked it, one was because it's the same color scheme as my PowerPoints, but also I think it's just really important to know that healthcare and quality, that's what I as a clinician am able to take care of only when the patient is in front of me. And I can give recommendations, but it's her decision and sometimes her circumstances that determine whether or not she's going to be able to follow through with them. When we look at the rest of this arch, and we look through the lens of the key informant interviews, this is the information that we are not necessarily going to see from a medical record, we're not going to see on a death certificate, but it is absolutely important and critical for us to know this information so that when we're pulling our information together and then going back into stakeholders and change makers that may not have lived this experience, this is where we're able to say, no, this is actually an issue and this is something that we need to be addressing. So we'll go through 2 case studies. They're very dense in the wording, and so don't be overwhelmed by that. I want to kind of focus on the quantity of information, but also the quality of the information. So we will go through this. If I am going too fast, please let me know. Okay. So our first patient, again, this is a story that we've heard many times with personal kind of elements pulled into it. But this is Leah, and briefly, she's 29 years old. It's her 3rd pregnancy. She's had 2 pregnancies in the past with 2 vaginal deliveries, and this is a background prior to her delivery. To highlight some things, she's had preeclampsia in the past. She still has hypertension in this pregnancy. She's obese. When she first came into her initiation of her prenatal care, she got baseline labs to kind of gauge where her morbidity is at just at the beginning of the pregnancy, her chronic condition at the beginning of the pregnancy, and her risk factors for progression. And then starting at 24 weeks of mid-pregnancy, she started having shortness of breath at almost every appointment, and they frequently and routinely and repeatedly gave her the danger signs of preeclampsia. At 34 weeks, she presented to labor and delivery with severe swelling and shortness of breath. Her blood pressure at that point in time was not considered to be elevated, and so she got preeclampsia counseling. 2 weeks later, she goes in, and her blood pressure is now considered to be severe range. She's continuing to gain weight. She has a headache. She has chest pain in the past 2 days. All of these things are pointing towards worsening of a cardiac condition and or preeclampsia. So she was sent to labor and delivery for induction of labor. This is her postpartum course. These are all the things that we go through at the MMRC meetings. She was noted on her labs to have elevated liver enzymes and low platelets. She had chest pain, and her blood pressure was continuing to rise. She was able to go through, I know, it's scary. She was able to go through her delivery process and had a vaginal birth. She was instructed to follow up for a blood pressure check in 1 week. We know now by Ames bundles that should be 72 hours. Again, this is not a real person. But on postpartum day 6, her family called an ambulance after she collapsed. She was in cardiac arrest. Her heart was markedly enlarged and not functioning by that low ejection fraction. And within 2 days, she had passed. Okay, all of the text that is underlined, this is from the key informant interview. Everything prior to that is just what our abstractors were able to get from the medical records. So you can see frequently when we are having the benefit and the privilege of speaking to a key informant interview, we are getting substantially more information than we got previously. And not only are they telling us a story, they're telling us important parts of her story. She only had 1 car. She lived in a rural community with limited resources. The child that she had prior, that in the pregnancy that was complicated by preeclampsia, was being evaluated for autism and required multiple visits, that she would make a decision to prioritize over her own health. She was trying to juggle work and appointments. Her finances were challenging, and as a result, she was not able to afford fresh fruits and vegetables. The provider that she went to was the closest provider to her home, but there were multiple family members that felt like her concerns about shortness of breath were being dismissed. But she chose to stay there simply because she could not go further away. And we've heard this story more than once. She waited for her regular visit, even though she knew that she was not feeling well, because she could not get childcare prior, and she had already arranged for childcare for the day of that appointment. When we go into her postpartum appointment, or her postpartum narrative, her partner was able to share that the lack of transportation, childcare, and difficulty getting time off work made it hard for her to attend her prenatal appointments and to make trips to the hospital when she was not feeling well. He believes that her complaints were ignored going to that discrimination and bias question on our Maria form, and she would have benefited to access to more healthcare and providers and facilities. He stated that there also needs to be a more public education on warning signs about heart disease for women that would encourage them to take care of themselves first. So GaPQC, you knew these things. You heard these things. You heard from the community saying we need more resources. And so what did you do? Look at that. Good job. So PEACH, so pregnant and postpartum heart disease warning signs. I cannot tell you how much I love this. As somebody who, my thesis in undergrad was looking at interpretive services in the healthcare facilities, and in 2007, sometimes that was just done by the chaplain if they happened to speak the language. But this speaks to, it gives you a mnemonic that is specific to our state that people remember. It gives you very short words to remember, but maybe you don't read at the level where you understand what a palpitation is, so then it gives you additional information underneath it for people with lower health or reading literacy. But also, if you don't understand English at all, it gives you these lovely pictures as well. I mean, thank you so much. This is such a fantastic piece of literature, and it is something that I think is very, very easy to digest, very easy to give out to communities, events, and so this is, I think, really going to be able to impact change. So good job. The other kind of more up and coming change to what we are noticing within our committees is the increased risk of mental health, suicide, and overdose. And so that's what Sabine is going to speak to now. Again, just a background, she's 24 years old. This is her second pregnancy. Of note, her first pregnancy we know was preterm because it says P0101, so that one in the second slot means preterm birth. And this is the information that we have for her. The only potential marker or risk factor that we see within this is that she's had a history of depression that she self-reported. We go into her postpartum period. She's had the baby. She comes in for her postpartum appointment, and she says she's very stressed. Her Edinburgh postpartum depression screen is 17. So just for background, this is a score of 0 to 30, and it is a standardized and evidence-based measure for people that are recently postpartum, because when you ask somebody if they're postpartum, if they've had trouble sleeping, of course, they're universally going to say yes. That's a different standard that you can hold them to. Anybody that is over the age or over the value of 10 is deemed to be at risk for postpartum depression. There are some studies that suggest that anybody with a score above 14 warrants medication. So she has a very high score of 17. She was offered a prescription for Zoloft, which she declined. She had had a repeat C-section, and she asked for a refill on her medication, which the provider declined. And she was told to come back to the office in 4 weeks, which she did not do. At 5 months postpartum, she was found unresponsive by an acquaintance at a friend's home, and she was pronounced dead with a fatal dose of fentanyl and methamphetamine. Again, looking to the quantity of information that the key informant interview is able to give us, and the quality of it. It was not documented well in the previous chart that it was a 28-week delivery via C-section with preterm birth and preterm water breakage. She was a single mom who had just come to Georgia, and her first child, who was severely premature, required frequent medical and physical therapy visits. She told her sister that she was overwhelmed and the sister told us that she had struggled with depression for most of her life, including overuse of prescription pain medicine and going into a treatment program when she was 19. This young woman, then went through a repeat cesarean section, major abdominal surgery, where narcotics is a part of that therapy plan in her provider, either because the patient chose not to give the information or the provider didn't ask, was giving more narcotics. She also reported that she had difficulty getting insurance, and that the baby that she had most recently stayed in the NICU for a week because it was having feeding difficulties. Going into the narrative with key informant information, she said that she was overwhelmed after her delivery and had feelings of regret about the baby, believing that she was a bad mom. There were no therapists that were accepting Medicaid in her area, and the wait list for teletherapy was 6 weeks. Her family became concerned when her children began missing scheduled medical appointments, and she distanced herself from the family, and they suspected that she was taking pills again. She went to a level 2 emergency room in order to find help, and she was discharged home with a recommendation to find outpatient drug therapy. And what they found was that they had extensive waiting lists and did not take her insurance. What we've also found is that frequently, if somebody with a small children or children, like that makes it more difficult for them to be able to go into inpatient facilities as well. And her sister stated that she feels her death could have been prevented if her family had better guidance about how to help her find treatment. They felt like they were on their own with trying to find accessible programs to treat her substance use and depression. So we can use Dr. Warren's slide about the National Maternal Health Outreach. And then, but we can also say, what has this conversation with this informant, this family member, what has this also contributed to our knowledge about what her experience was like and what the experience is for many new moms in Georgia? And what we find is that they can speak directly to the descendant's thoughts and the feelings prior to, during, or after the pregnancy or leading up to the death. And they can give us specific statements or actions that helps us when we're filling out that Maria form. Was mental health a part of this? Or was it that she had chronic pain and she just accidentally took too much medicine? Those are important because those are different charges, those are different ventures for us to go through as we work through our public health stakeholders and companions. So, what can we do as a state that is the same or better as the PEACH forms? What can we do so that we are raising this awareness and also providing information? Because preventability is much more than just what happens in the hospital. And I think when we see, on the newspaper or online or spoken at the Capitol that 90% of our deaths are preventable, there's only so much that people in the hospital can do. We need to be the village that's taking care of the family and taking care of the mom so that she can raise her child. That's it. It's really easy.